Hi, everyone, and welcome to today's session. My name is David Odij. In this lecture, we'll be exploring medications used to treat conditions related to fluid, electrolyte, and acid-base imbalances, some of the most critical aspects of maintaining homeostasis in the human body. Fluid, electrolyte, and acid-base imbalances are critical in maintaining homeostasis. Uncompensated imbalances can lead to severe health issues. Understanding the mechanisms and effects of these imbalances is essential for effective management and treatment, ensuring optimal patient outcomes. Hypernatremia means a high sodium level, usually caused by dehydration or sodium overload. Our main goals are to restore water balance and reduce sodium safely, never too fast. Let's look at the key medications used. Normal saline is an isotonic fluid. In hypernatremia due to fluid loss, we use NS to restore intravascular volume before correcting sodium. But remember, NS can cause fluid overload and hyperchloremic metabolic acidosis with large volumes. As nurses, we monitor vital signs, lung sounds, daily weights, and serum sodium closely. Slow and steady correction prevents complications. 5% dextrose in water is sodium-free. Once dextrose metabolizes, it becomes a hypotonic solution, helping dilute high sodium levels. A major caution is hyperglycemia, so diabetic patients need extra monitoring. Nurses must check serum sodium frequently and ensure the infusion rate is appropriate to avoid rapid correction. Loop diuretics like furosemide help eliminate excess sodium through the kidneys because they can cause dehydration, hypokalemia, and hypotension. Monitoring electrolytes, especially potassium, and daily urine output is essential. Teach patients the signs of dehydration such as dizziness and thirst. Hyponatremia means low sodium levels. Treatment depends on the cause, volume depletion, dilutional causes, or SIADH. Correcting sodium too rapidly can cause osmotic demyelination syndrome, a life-threatening complication. So sodium correction must be controlled and carefully monitored. In hypovolemic hyponatremia, isotonic saline helps restore both fluid volume and sodium. We look out for fluid overload, especially in patients with heart failure. Daily weights, intake, output, and frequent sodium checks guide safe correction. Hypertonic saline is a powerful option used for severe hyponatremia, especially with seizures or coma. Because it can cause rapid shifts, it's only given in ICU settings with continuous ECG monitoring. Nurses check sodium every 1 to 2 hours to avoid overcorrection. In dilutional hyponatremia, loop diuretics help remove excess water while preserving sodium levels. However, they increase the risk of hypokalemia and dehydration. As nurses, our job includes electrolyte monitoring, blood pressure checks, and replacing potassium if needed. Demeclocycline creates a reversible nephrogenic diabetes insipidus effect, reducing water retention in syndrome of inappropriate antidiuretic hormone secretion, SIADH, but it carries risks like photosensitivity, nephrotoxicity, and is contraindicated in pregnant women and children. Nurses should educate patients on sun protection and monitor renal function closely. Conivaptan is intravenous. Tolvaptan is oral, but limited due to risk of liver injury. These medications block ADH receptors, causing free water excretion, ideal for SIADH or hypervolemic hyponatremia. Nurses monitor sodium frequently, check liver function, and educate patients about increased thirst and frequent urination. Hyperkalemia is dangerous because it can trigger life-threatening arrhythmias. Treatment focuses on stabilizing the heart, shifting potassium into cells, and removing excess potassium from the body. Loop or thiazide diuretics, administered daily, enhance renal potassium excretion, reducing serum potassium. Side effects include hypokalemia and dehydration, contraindicated in anuria and severe hypovolemia. Monitor electrolytes, renal function, and blood pressure. Pataromer, a calcium-potassium exchanger, manages chronic hyperkalemia. Pataromer works slowly and may cause hypomagnesemia. It must be separated from other oral medications by at least 3 hours. Sodium zirconium, Cyclosilicate acts faster but adds sodium, so we watch for edema. Sodium zirconium cyclosilicate binds potassium for fecal excretion with rapid effects. Monitor for potassium and fluid status. Sodium polystyrene sulfonate exchanges sodium for potassium in the gut, aiding potassium removal. Watch for constipation and rare bowel necrosis, especially with sorbitol. Always assess bowel function and avoid use in patients with recent bowel surgery. Insulin drives potassium into cells, but it can cause dangerous hypoglycemia, so we always give dextrose with it unless the glucose is already very high. Nurses must check blood glucose frequently after administration. Nebulized albuterol stimulates beta 2 receptors, shifting potassium into cells, but may cause tachycardia and tremors. Monitor heart rate and serum potassium closely. This therapy is an adjunct, not a standalone treatment. Potassium chloride administered orally or via intravenous replenishes potassium to address hypokalemia. Oral intake may cause gastrointestinal irritation, while intravenous requires careful monitoring to prevent hyperkalemia. IV potassium must never be given as a push, only diluted and infused slowly, usually 10 milliequivalents per hour. Nurses monitor ECG, check urine output, and educate patients about potassium-rich foods. We encourage potassium-rich foods for mild hypokalemia: bananas, spinach, oranges, potatoes. But remember to avoid high potassium diets in patients with renal failure. Educate patients on dietary sources and monitor potassium levels closely. In hypercalcemia, the goals are hydration, inhibition of bone resorption, and enhancing calcium excretion. Intravenous isotonic saline is used to hydrate and increase renal calcium excretion, but this can worsen fluid overload, especially in heart failure patients. Monitor lung sounds, daily weights, and urine output. Calcitonin lowers calcium quickly but temporarily. Its effectiveness wears off within days. Nurses monitor for nausea and allergic reactions and check serum calcium frequently. Intravenous bisphosphonates inhibit osteoclasts, reducing bone resorption. These drugs inhibit osteoclast activity, making them excellent for malignancy-related hypercalcemia. Full effects appear in 2 to 4 days. Monitor renal function and assess dental history due to the risk of osteonecrosis of the jaw. Denosumab, a receptor activator of nuclear factor kappa V ligand inhibitor, is administered via subcutaneous injection per oncology or endocrine schedule. It inhibits osteoclast formation and function, particularly useful when bisphosphonates fail or in cases of renal impairment. Side effects include hypocalcemia, infection risk, and osteonecrosis of the jaw. Monitor calcium levels, ensure dental hygiene, and report any jaw pain. We're starting our journey into medications used to manage acid-base imbalances, a critical topic in patient care. Acid-base balance is essential to maintain normal body function. When this balance is disrupted, patients can develop conditions like acidosis or alkalosis, which can quickly become life-threatening if not treated properly. Hypotonic solutions like 0.45% sodium chloride and 5% dextrose in water are used to dilute extracellular fluid, shifting water into cells. They treat hypernatremia and uncontrolled hyperglycemia, but can cause cellular swelling and cerebral edema. Monitor mentation, sodium, and blood pressure closely, avoiding rapid infusion to prevent increased intracranial pressure and other complications. 3% sodium chloride, a hypertonic saline, is used for severe symptomatic hyponatremia and head injuries. It pulls water out of cells, increasing serum sodium. Side effects include pulmonary edema and fluid overload, with contraindications in heart failure and renal failure. Administer slowly, monitoring sodium levels, lung sounds, and blood pressure. Dextrose 10% in water provides calories, becoming hypotonic post-metabolism, used in parenteral nutrition support and severe hypoglycemia. Monitor for hyperglycemia and vein irritation. D, 50.45% sodium chloride provides sodium, chloride, and free water, used for maintenance in hypernatremia. Watch for hyperglycemia and fluid overload. especially in heart failure or renal failure. D5 0.9% sodium chloride offers a high sodium and chloride load, useful in metabolic alkalosis but risky for hypernatremia. Monitor electrolytes closely. D5 0.225% sodium chloride balances hydration, becoming hypotonic. Monitor glucose and hydration levels. Colloids expand plasma volume more effectively than crystalloids. Albumin 5% is administered as a bolus to expand plasma volume, used in hypovolemia and shock. Monitor for fluid overload and pulmonary edema, especially in heart failure or renal failure. Albumin 25% is infused slowly, pulling fluid from tissues to the vascular system, used in burns and hepatic failure. Dextran expands plasma volume significantly, used in hypovolemia and surgery, but may cause anaphylaxis and bleeding. Monitor coagulation and vital signs closely. Hydroxyethyl starch, or Hispan, is used in shock and trauma to increase intravascular volume. It carries risks of anaphylaxis and renal injury, especially in renal failure or sepsis. Packed red blood cells restore red blood cells and oncotic pressure, crucial for anemia and blood loss, but require compatibility checks. Whole blood replaces red blood cells and plasma, essential for major blood loss, but may cause overload, necessitating diuretics and close monitoring. We appreciate your attention and engagement throughout this presentation. Your understanding of these complex topics is crucial for effective application in practice. Thank you for your dedication to learning and improving patient care.